Good afternoon. I'd like to call the Emergency Policy Group meeting to order. Will the clerk please call the roll?
Good afternoon, Miller.
Here.
Overman.
Here.
Merman. Merman.
Wait. Yeah, here.
Cronister.
Here.
Caster.
Here.
Ross.
Here.
Lott.
Here.
Snively.
Here.
And Mr. Merrill.
Yes, I'm here.
Thank you. You have a quorum.
Thank you. Did public comment? I don't have a list of anyone wishing to speak. Am I correct?
Commissioner Miller sent it out early. I'm sorry, Secretary Director of Communications, you have one, a Kim Pullen.
Kim Pullen on the line?
Yes, sir.
Yes, ma'am. You're recognized.
Thank you, Mr. Chairman. Good afternoon, everyone, and thank you for allowing me to speak to you today. As stated, my name is Kimberly Pullen, and as a mother, wife, daughter, and nurse, and Hillsborough County resident, beginning the reopening of our community has personally caused an increased level of anxiety, not only for my individual family, but also for our local healthcare system. My greatest concern at this time is the lack of use of masks or face coverings by the general public, as well as essential workers. During the short periods of time I have had to leave my home for activities such as grocery shopping, approximately 50 to 75% of the general public, as well as frontline essential workers, are still not utilizing any type of face covering, which is greatly concerning to me. Especially due to the potential of increased asymptomatic spread of COVID-19 throughout our community as we begin to allow additional freedom of movement. As we continue through the phases of economic recovery and community reopening, my greatest fear is that our local healthcare systems could potentially become overwhelmed with new cases in the coming weeks if the use of face coverings and other mitigating factors are not being appropriately utilized. So at this point, excuse me, I would ask that the EPG provide guidance to our local business leaders, strongly urging them to require not only their employees to utilize face coverings while on shift, but additionally require patrons to utilize face coverings when in confined public spaces, such as grocery stores, especially when appropriate social distancing may not always be possible. As we continue this road to economic recovery, which I think we're all excited to be on, we still need to ensure that we are protecting our frontline essential workers, their families, as well as all Hillsborough County residents. Thank you again for your time.
Thank you very much, ma'am. Appreciated your comments. Thank you. Mr. Wagner, are there anyone else?
No, sir, Commissioner, that was it.
Okay, thank you. We're now moving to emergency management update. Mr. Dudley.
Good afternoon. Here at the EOC, we continue to support the testing sites at Raymond James, Lee Davis, South Shore, and Plant City. Total kits we have on hand is over 6,000. And I'm excited to report the team's hard work and efforts. We're reporting over 10,000 collections to date, where we started at Raymond James on March 25th. So I'd like to thank the teams and all their hard work. And this came right out of a total community effort. And we continue to work hard. Totaling this week, as of a close of business on the 6th, we have over 2,400 collections just for this week, and we're projected another 1,638 through Friday. If everyone shows up, that'll put us a little over 4,000 collections for the week. So outstanding effort for the teams. We continue to increase testing daily. I like to thank the public for taking advantage of this resources that we're offering, so we can continue to move forward through this event. For right now, next week, we have over 1,400 scheduled and still taking calls. Also like to point out on the slide there that we've had over 102 mobile testings as of this week. So that's an outstanding effort for that resource as well. PPE distributions, we've had changes for gloves, masks, shields, and gowns. Those numbers continue to increase as we get those resources from the state. We push those out as quickly as possible to support the effort. We've had no changes in the numbers on the donations, but we will have operation change starting next week. We'll still be open from 9 to 3 at the donation site at 250 West Shore Plaza, but the days of operation will be Tuesdays and Thursdays. Also, at this time, we have 1 guest in the quarantine site and 6 guests in the isolation site. This concludes my update. Any questions?
I don't see any hands, Mr. Dudley, at this time, so thank you so very much for your presentation. Appreciate it. Thank you. Mr. Dr. Holt, Public Health Update.
Yes, sir. This is Dr. Doug Holt, Florida Department of Health, Hillsborough County. I will begin by reviewing the EPI information, which will be followed at the end of my presentation by Kevin Wagner and his graphic display of the data. I will also review the progress we've made on building the public health capacities as we are reopening. And I do want to focus some discussion on our long-term care facilities. First, the EPI. We've reported 1,364 cases as of this morning. The trajectory of the number of new cases has increased over the past 7 days compared to the prior 7, and the same would be true for the 14-day period. I think it's important to point out that the number of tests that have been run in the last week, this first week of May, are 3,000 tests more than were reported in the 4th week of April and 4,000 more than were in the 3rd week of April. So good news from this is we've seen our percent positivity of all the tests going down. Secondly, I would like to point out the impact of some very targeted strategic testing of facilities can significantly alter the numbers of cases. In our recent week, we've had about 50% of our cases that have been found when we did testing, widespread testing at 2 facilities. So essentially, we got 50% of our cases from about 10% of the tests that were run during this period of time. The hospital syndromic-based system for chief complaints of people in the visits or admitting has showed decreasing trends for influenza-like activities. We've had 36 deaths now reported. We now have 133 in the hospital. That's up from 48 1 week ago. But if you look at the detail, there's no change in the numbers that are in the ICU or on ventilators. Again, this is directly linked to proactive testing and proactive transfer of residents from our long-term care facilities. Quick update on the public health capabilities. The testing program, as outlined by Mr. Early, and as part of the public-private partnership, is continuing to show success. The public-supported community-based testing has being described by Mr. Dudley is continuing to be very outstanding. We have tested, by my calculation, 1.9% of our population. Our contact tracing, we have 2 now employed additional staff from the state. We've had 2 more pending. And the College of Public Health, our partnership with their tracers is finalizing with some specific assignments and oversight that is necessary for them to begin their work. Thirdly, or lastly, long-term care facilities. I knew as all along that I would have to give this more complete report, and here we go. Before I talk about the numbers, I would like to tell you some progress. In the cooperation of the healthcare leadership, we have formed a task force that will have conference calls twice a week. The members would include all of the hospitals, Florida Department of Health, ACA, Emergency Operations Center, and others. The purpose of these is to real-time share information about what we know and what we're doing with each of the facility, whether they have a known case or not. We keep everyone updated, and we'll coordinate any response if needed. We are continuing to work towards finalizing the partnership with the USF College of Nursing, so we will have nursing supported teams both in the facilities and could respond as needed. We have utilized local resources that really can provide what is the most important thing you need in this is immediate information, timely information, so you can make informed decisions on what is best to do with the residents. Early warning systems, an alert medical director, director of nursing at the facility or local hospital, and emergency room or infection preventionist are also critical. The major emphasis, as I've outlined previously, is the safe disposition of anyone found to have COVID-19 in a long-term care facility. To do this, we must identify who's positive, infected, and who's not, and implement processes to separate those. Florida Department of Health and ACA will do an immediate assessment of a known case and assess their infection prevention practices. We assess the potential of the risk for a relative potentially explosive cluster. Access locally to our hospital testing system allows us to do some targeted testing of symptomatic residents and as many staff as necessary, probably the most critical piece of information you can have. Once we have this, we can assess the population that are infected, separating them from those that are uninfected, and staff or furloughing. Excuse me. To date, we have had 15 long-term care facilities that we are working with that have had a known case either in a resident or staff. 8 of these are nursing homes. We've had 2 large facilities that represent 80% of the cases in this population. I would note that these are 2 facilities that have completed widespread testing of both residents and staff. We do have 1 nursing home that has not had a case for over a month, and 5 others that we are actively have been inspected, we've educated, supplied, and we are actively monitoring for additional cases. The ideal process, just to review, again, emphasizing it's all about rapidly getting information that's accurate, because the bottom line that we all are working to achieve is the fewest numbers of deaths in this patient population. The facilities will be expected to do all they can to keep out the virus, particularly no visitors, but screen all staff. We can then promptly recognize anyone that might have an illness that could be COVID-19 to test them with rapid turnaround time. With the prompt inspections, we can then begin to remedy any deficiencies or supplies and support with the education that they needed. Then based on the positive or the results of our testing, we will do the disposition and separations. The monitoring then begins of the symptomatic patients that are remaining in the facility. The challenge we're now facing has quite a bit more to do with, as we proactively transfer patients, it is a matter of having a plan and a safe way to manage them in their current location, looking for potentially alternate sites besides just the hospital, which have done a remarkable job to date. With that, I'll close there and ask Kevin Wagner to review his slides.
Before Mr. Wagner comes on, I think Mayor Ross has a question. Mayor Ross, you recognize.
Thank you, Mr. Chair. Dr. Holt, you've mentioned the other day and you mentioned again today the proactive hospitalization of people from the long-term care facilities. Our numbers have jumped dramatically in the hospital from 48, I think it was, to 133, and it was up from an even lower number before it went to 48. Can you talk a little more about this proactive hospitalization? Are these people that are sick and positive in nursing homes that are being moved to the hospital that would not have been moved previously? Or are these people that are being testing positive but not sick that are moved to the hospital? I'm a little unclear as to exactly who's being moved to the hospital and under what conditions. Could you speak a little more about that, please?
Yes, sir, I'd be happy to. These the majority of these patients are not moved because of their medical necessity. They are tested positive with COVID-19. To properly care for them requires a fully separated space in an existing facility with some aggressive and extensive infection prevention practices that typically are not found in the typical long-term care facilities. Not to say that there aren't some, just we look at it case by case. The hospitals take a proactive decision as to what's best for this community and would prefer to transfer those at this time if they are unable to be safely cared for and separated from their other residents in the remaining facility. That is because these patients have an extraordinarily high probability of quickly deteriorating and need prompt response. So it's an active monitoring of people that were pretty much in their usual state of health until they came back tested positive. And then the challenge that we're working as a system is at what point after their recovery, where to best return them. I'll stop there.
Okay, so the increase in hospitalizations then doesn't necessarily reflect an increase in the spread of the virus. It's a different way of we're treating this differently now that we have hospital space available.
Yes, sir. You're exactly correct. The situation we anticipated previously would be of people that were normal or had previously been overwhelmingly requiring medical necessity to access hospital care. Now we have people that are that it's just better to closely monitor in the only place we can right now, and that's why we see the numbers going up.
Okay, that cleared it up for me. Thank you, Doctor.
Mayor Castor, you recognize.
Thank you. Dr. Holt, I'm very concerned about these nursing homes. We've got several, we had none, and now we have cases in several of them, and it clearly, we all know it spreads very quickly in those locations. And I know we're doing that all of the staff are being screened when they come in, but what's the possibility of testing? I know, I believe that you and I, in our discussions, you said there's over 300 long-term care facilities in the county, and I think there's 88 of them in the city, or 80 something in the city. So number one, it appears to me that would probably be the best use of our antibody testing, is to find out who on those staffs may have had it and not known, and so could clearly work safely. And then the ability to test everyone, because learn more and more that there are a lot of individuals that are asymptomatic. So even the best efforts on the part of the long-term care facilities still clearly, these cases coming through can't stop it. So that's what we can do to deal with that. And then secondly, is contact tracing for the staff that works in these long-term care facilities. Like, what kind of contact tracing are we doing? Because the individuals that work in those are usually, from the Black and brown communities. And so we would be identifying potential clusters in neighborhoods around the county, doing contact tracing for those staff members that have tested positive. Thank you.
Yes, ma'am. I'll do my best to answer. The first question had to do with the utility and the availability of testing in both the staff and the residents in these long-term care facilities. That's clearly Governor DeSantis's initial priority. We've got access to two days a week, some teams that we can try to get some facilities that request testing. This is not based on a public health immediate need, such as a number of cases or something that we would be alarmed about. Then we would try to use our other resources to do that in a targeted fashion, like was done in one of the facilities that I talked about earlier. But each facility has also been doing, some facilities have been doing phenomenal jobs in testing their own staff and residents. There were two ALFs, and they tested every resident and they got 0 back. And another that have so far of their almost 150 tests, 100 of them have all come back. So some have had the availability to take that initiative and done so, and we applaud them. But we also know that our intention is to bring more and more of those testing resources into this community and this population. The antibody testing is certainly this is the type of use that this has been projected or proposed to be useful for. But there is still some scientific questions that employers and others need to understand the limitations of that test. Now I apologize. Now I can't remember the second part of the question.
It was the antibodies. Now the governor, I think I heard him say we received 100,000. The state did antibody tests. Do you know if those are going to be aimed towards these long-term care facilities?
What I've been told and what I've understood from our calls and things is they refer to as healthcare workers, and that should include at least the staff of these long-term care facilities. The distribution of those tests have not reached our county at this time, but we certainly have indicated we would happily receive them when they're available for us. I'll stop there.
Okay, thank you. And the only last thing, Chairman, I swear, is what's the turnaround time on those tests? I heard 5 to 7 days. So if you're testing the long-term care staff, do you have an idea of how fast those test results would come back?
Yes, we've had 2 experiences. And again, when we can do some things locally in cooperation with our hospitals partnerships, and this is, on a selected basis, we get the results essentially the same day. It's a very powerful tool. The testing, but it is limited. They do not have the capacity to test all. The ones that are now, the governor has authorized, which is the National Guard-based types, are contracted out to commercial labs. And we've worked through 2 examples now, and 5 to 7 days is the time frame that our experience has been to get those results back. I'll stop there.
Thank you. Thank you, Chairman Miller.
Oh, yes, you're welcome. I see no more questions. We're going to move to Mr. Wagner and Mr. Early, COVID collection, testing, and case management data update.
Thank you, Mr. Chairman. Do you see my presentation on the screen, sir?
Yes, sir.
All right, thank you. My name is Kevin Wagner, Business Analyst for Healthcare Services Department. The first 2 slides of the small deck are going to reinforce or re-update the information that Director Early's presented to you all on Monday with regard to testing. The data he presented was through April 23rd with testing for the providers, the hospitals, Raymond James. This update will just be through April 26th through May 2nd. With that being said, because of the turnaround time, it's not a complete set. All the providers were unable to give us the testing results of this week timeframe, but most did. We will continue to streamline that process to move forward. But for that week of April 26th to 5/2, May 2nd, there were 7,018 tests completed in Hillsborough County, a majority by the providers, Raymond James, and the community resource centers. So what does that mean from a breakdown standpoint? Of the 7,000 tests, 68%, over 4,700, were provided by the providers, the hospitals. And again, this is not a complete picture. We did not get all the provider data. There's probably more tests that we know that we're missing. Raymond James in that time frame had 935, about 13%, and the CRCs, the mobile, were 1,322 tests. So from a breakdown standpoint, there was at least 7,000 tests that we completed in Hillsborough County through various outlets. Piggybacking on what Dr. Holt had said regarding the overall public health, for Hillsborough County, there's been nearly 26,800 tests completed to date through 5/6. A vast majority of those, 25,400, have been negative, and 1,331 were positive. That was as of yesterday, which is under 5%. Dr. Holt said 1,364 today. So again, you've seen that positivity range go down from when it started at 6% to now under 5%. As alluded to earlier, the testing has increased since May. The beginning of the testing results increased since May. The blue line here shows the number of test results daily received. This is what we showed you last Thursday by myself. As you can see, starting on May 1, there were nearly 1,500 test results that came back that day, 800, 1,200, and 800. So we are getting a lot more test results in daily through this process, and the trend line of that has increased. The green line at the bottom is the number of positive cases resulted each day from those test results. Again, starting in May, we saw a little bit higher numbers with 39 and 77, but again, you're getting more test results in, and we've seen as of 19, 24, and 7 individuals. So the overall average per day roughly is about 24 cases still for Hillsborough County. But again, we are seeing more test results coming in. From the positivity and negative standpoint, this is the 7-day look at. So for the week of April 26th to 5/2, 96% were negative, which is very good. The week of 5/3 through 5/9, which hasn't been completed yet, but we're looking at a 98% negative clip. But again, that week hasn't completed. But again, the higher trend is better on the negative standpoint, as we all want and know. The previous slide was the 7-day. This is the 3-day. Again, the trend is going very much higher. I'll repeat myself that the numbers are looking good from a positive and negative standpoint from the number of test results getting back. On the far right-hand column, from 5/4 to 5/6, there were nearly 99% of the test results coming back were negative. Again, that's on the 3-day look. The single daily look on any given day, we are in the mid-90s to high 90s. Even this past week, I've been in the high 99 percentile of negative test results versus positive. With all the testing information, we've always talked about the population percentage tested. This number has slowly creeped up. We're at 1.82%. Theoretically, of the population's been tested. Again, I can't account for people who may have received that test more than once. But right now, it equates to about 1.82% of the individuals tested in the county. I'll stop there if there's any questions.
Thank you, Mr. Wagner. And I see no questions at this time. No questions. Thank you very much. Mr. Early? Mr. Early on?
I don't have anything further to add, Commissioner.
Okay, all right. Thank you very much. Thank you. We're now moving to presentations of Aspect, Geo-Fencing, and Contagion tracking systems. We have Dr. Matt Mullarkey and Dr. Peter Chang.
Thank you, Chairman. As the slide presentation is being pulled up, we appreciate the opportunity to share with you and the EPG this project Aspect, which has been equally sponsored by Hillsborough County, Tampa General Hospital, and the University of South Florida. Project Aspect is really two things, and those are the things we're going to show you today. The first is the idea of around understanding geofence contagion tracking system, totally anonymized systematic population geofence contagion tracking, and a comprehensive decision support dashboard approach. Next slide. As by way of overview, I have to recognize Ramin, CIO for the county. Dr. Peter Chang and myself have been working on this approach for the last 5 weeks in terms of sharing with you what we have today. However, it's particularly pertinent in terms of where we are with phase 1 plan for reopening, which is underway. So what do we know for sure? With phase 1, movement around the region will grow. Some types of movement will increase the risk of spreading this virus. The challenge is, how do we measure, how do we predict, and how do we understand how it'll affect our capacity to treat COVID patients, which will tend to grow in the current environment? And how do we get ahead of it so that if we can cut off any clusters or any outbreaks, and we can plan the capacities in our hospitals to support and stay ahead of the disease and still open our economy. Second point, the data requested, received, and presented to the EPG at this point has an opportunity to move from disparate to comprehensive, has an opportunity to move from descriptive to predictive or even prescriptive, action-oriented. And our goal with you today is to talk about the evolution of this process to move from informative to actionable. So what we're going to show you today are 3 dashboards: the capacity dashboard, testing dashboard, movement dashboard. And ironically enough, in the task force for the governor, these relate directly to the governor's metrics or the task force metrics around capabilities, outcomes, and spread. And what we are trying to do is answer these questions, these pretty straightforward questions. How does each reopening announcement phase affect movement? How does a type of movement affect risk of spread? How can we identify the 5% that will be the most likely to spread this virus and intervene proactively? How will the movement behavior consume hospital capacity? And how will we adjust models through feedback from testing and tracing, which you saw a little bit earlier in today's presentation? I do want to acknowledge that Pete and I are sort of the tip of the spear here, along with Ramin, and we acknowledge the medical professionals and data science research colleagues who have helped us design, develop, and deliver, and will continue to deliver the information you're going to see here on a daily basis going forward. Next slide. Caveats. I want to make two really important caveats. The first is that every bit of the data you're going to see on these dashboards contains no personally identifiable information, contains no HIPAA protected information, complies with comprehensive data protection laws in 80 plus countries, including the two most aggressive laws in GDPR and the California Consumer Privacy Act. And all device data that I'll show you is opt-in, and all of it is cleaned daily for opt-out. The other thing I want to share with you is that the analysis that we are performing here attempts to move us away from samples, particularly self-selected, biased, or skewed samples, toward massive data across populations. So we're looking for population behaviors. We're looking for aggregation, but we're also looking to do that at the level of geofence, literally down to square blocks, if needed. I will also tell you that it's not deterministic. Everything I'm going to show you is a probabilistic approach with levels of confidence. But if we say it's statistically sound, you'll understand that it's in that high degree of confidence. The other thing I want to talk about is just briefly understand that when we want to understand, what we're trying to do is really understand the underlying behaviors and movements and how those behaviors lead to outcomes. And this is really interesting because unlike most of the models you've seen thus far, which relate to Johns Hopkins data, Wisconsin data, Washington data, Italy data, this data that we're going to present to you is our demographics, our density, our movement behaviors, and our social behaviors here in our region. Next slide.
Great.
With that, I'd like to turn it over to Pete Chang.
Thank you so much, Matt. So I know some of you have seen some of these dashboards before. We've really created 2 out of the 3 dashboards that Matt referenced. The one that you're looking at right now is a hospital collaborative between Tampa General, Advent, Baycare, and HCA. And so really thanking all the CEOs for allowing us to submit our data. This data comes directly into Tampa General, and we create this dashboard. So this represents about a 9-county area on the west coast of Florida. Currently, right now, as you look in the top right-hand corner, there are 392 positive COVID patients in these hospitals. 96 of them are in the ICU, and 33 of them are on ventilators. When you start looking at the left, you'll start to see that 54.6%. What that represents is our ICU utilization. So when we talk about hospital capacity, we look at it in 2 veins. We look at it at how many COVID patients we have and how many non-COVID patients we have, because that determines our capacity to take care of all comers when they arrive in our emergency departments. So as you can see here, both our acute care or just inpatient beds and ICU capacities have been running between 50 and 55% for the last 3 or 4 weeks solid. Our ventilator capacities, I don't have an interactive dashboard, but if I did, I can click on ventilators up in the top and you'll see that we're running at anywhere between 15 and 18% of our total ventilator capacity amongst all of these hospital systems, which is great because that means we have, many other ventilators to use for patients should we experience any sort of surge. The bottom graph you see is just the historical trend. Those orange bars are the number of total ICU patients. And then the red little bars at the bottom of the orange ones are the number of COVID patients that are in the ICUs. Over to the bottom right, you'll see the dashboard representing each of the hospitals and how many ICU beds they have as total capacity. We can sort this by county. We can slice it and dice it as we look at it. So let's go ahead and move on to the next slide. It's really the same dashboard that you'll see. Can we get the next slide, please? There we go. As we look at the next dashboard, it's the same one, except we layer on top of it some of the predictive modeling we've been working on. We've been working very closely with IBM Watson Health to look at how we can predict, how long this tail on the number of ICU patients are going to be. This is just looking at strictly ICU capacity. You can see when we had the outbreak at our 2 large skilled nursing facilities in the county, what ended up happening to the ICU capacity in the last couple of days. And that's really what you see represented kind of in the middle of that chart. So again, we're able to kind of create some generic predictive models, but we want to be able to get maybe a little bit more specific so we can really tell what the outcome is going to be as we reopen for business. Next slide, please. I wanted to spend just a couple minutes on the medical front to really show you guys the impact of what skilled nursing facility and assisted living facility outbreaks mean to the number of COVID diagnoses that we get and the impact it has on hospitalizations and patients passing away. So just some really interesting statistics. This is pulled from maybe about 2 days ago. When we look at the age bracket of 65 and older, 26% of all cases, of all COVID positive cases, are in that age bracket. Over 50%, specifically 55% of all hospitalizations are in 65 and older. And then the most significant one to me is that 83% of the deaths in the state of Florida are due to age group 65 and over. So we can talk about comorbidities, we can talk about all sorts of other things, but age to me is the biggest predictor of how patients will do and what the impact will be on hospital utilization. And then most importantly, how many lives will be impacted by loss. So as we start to open up, I think the biggest thing to take home from this slide is to really, how can we build sort of a net, a protective layer around our 65 and plus community to really help protect. And that includes some of the ideas that Dr. Holt alluded to earlier with creating healthcare strike teams to go in and really assist some of the skilled nursing facilities that were experiencing or could experience a potential outbreak. Next slide. This one I'm very proud of from the TGH perspective. We started testing. I did see the testing dashboards, and you'll see some very familiar trends and outlines here. This is the dashboard we created about 8 weeks ago to start tracking our testing as we starting hospital-based testing in March. And if you look right under the resulted on the top right-hand side, you'll see that last night we just crested over 10,000 samples resulted within our hospital lab. So great accomplishment there. But we're able to track on this dashboard what I like to call testing density. And so, it was interesting. I was teaching my 9-year-old how to define density, and it's mass per unit volume. Or in this case, we're really looking at number of tests per population, or number of positives per population. That's what defines the density. So when you start to take into account, just remember these concepts as Matt moves into the movement dashboard. So to kind of recap, you've had your capacity dashboard, you have your testing and positive dashboard, and then you have your movement dashboard. All these three may coalesce in the future, but what we really want to do is create actionable items for the county, the city, all of our community leaders to react to really figure out what are the actionable items that we can do in regards to monitoring, interventions with the Department of Health, mobile testing strategies on really helping to try to contain that 5%. So as you look here in some of the central zip codes, you can see the size of the dot equals the number of positives, and the more orange a zip code is the more tests that we did in that zip code. So when you start to look at the movement data, you can layer on the risk of movement into how well we're testing in that area, and as it relates to the number of positives that are coming out of that area. So with that, I'll pass it back to Matt to really dive into some of the movement data.
Thank you, Pete. Next slide. So as we began the process about 5 weeks ago, Pete and Ramin and I realized that we were building out the capacity dashboard. We were going to get to the testing dashboard, but in both cases, those are outcome-based looks. By the time people show up at testing and by the time they show up at a hospital facility, the chances are that not only has the virus spread to them, but it's spread to a community of some size around them. And so we decided to look at all of the mobile apps that are out there and any other thing that would give us a predictive power by looking at movement and try to understand movement related to spread of the virus, right? And as a consequence of that look, took us about 2 weeks, but we could not find a significant identifiable app that would do this for us. And so we went to a data partner, Mobile Walla, after surveying a number of data partners. And what I'm going to show you is a product of the fact that our data partner has geolocation data daily on some 3 million devices across the 13 counties and 5 million people. Again, completely compliant with all of the privacy protection acts and laws in our country. So none of this is personally identifiable and none of it is correlated with any or is specific HIPAA data. Having said that, what we did do with our mobile data provider is look very closely at the reality that says, and what we discovered is that there are really 3 types of movement that affect risk. And so what I'm going to talk about is a risk factor as much as anything else that is a good proxy for this behavior. How far any individual device traveled in a day is a factor. The number of unique locations that device visited increases the risk. So how far a device traveled between 2 locations, home and work, is a factor, and it's more risky for the spread of the virus than if that mobile device just stayed in one location. If it also travels between multiple unique locations, that's a higher risk, and we can assign that and vector that. And the third thing is if it travels to multiple different dense locations, the risk score would naturally go up. At the individual level, not as interesting as at the aggregate. And all of our 51 hospitals have small aggregated geofence zones around them that are interesting for this data. And when we geofence it, we can take median scores and in fact have found that the top 25 most mobile devices are going to be very indicative of the overall risk factor for that geofenced area. Working with Mobile Walla, we were able to work with them and understand that there is a statistically sound correlation between, and the model that we are presenting with them has been trained usually using actual new cases for thousands of devices across hundreds of zip codes across our country. And the social isolation score that is presented in the following charts is statistically correlated with numbers of new cases. Next slide. So what I want to do is show you 3 heat maps. The first heat map, the redder the county or the redder the geofence location, if you think about the map on the left, think about the 51 hospitals. On the right, it's the broader geofenced across the county. If you think about these, the redness indicates the higher risk score on aggregate. Okay? This is March 18th before the shelter at home order was given for the state. Next slide. Look at the same map on April 5th, about 4 days after the shelter in place. Now, ironically enough, for 2-3 days immediately following the shelter at home, guess what the map did? Of course, it got very red as people went out about and found and collected and purchased things. But by the 5th of April, you can see that most of our region was sheltering in place. Later, next slide, you'll see that by the 22nd of April, it got a little redder. And it pretty much stayed at about this level of movement for the duration up until a week ago Wednesday when the announcement came out. And on Monday, the maps changed again. I don't have those for you. They're in the process. But come Monday, I'm excited to show you those on a daily basis. Next slide. So this first 3 slides gives you an idea of what is the overall risk of the movement behavior in our region and the probability that it will lead to a spread of disease. the spread of the virus. So it won't surprise you that there is a direct correlation, I don't think, between the movement behavior and the spread behavior. And we can measure that, and we can measure it objectively, and we can share that with you in a meaningful way. But now it gets interesting, because once we do that, you can see a chart like this. This is a chart that represents the movement of the social isolation score around Tampa General Hospital. And it compares the risk score changes, see back on March 16th, all the way through April 11th was the latest we had this chart up to date. And then it compares it to number of mobile devices that showed up at Tampa General Hospital 14 days later. Look at the amazing correlation over the period of time. And what we have done, this is 2 weeks ago's worth of understanding. What we have done starting Wednesday of this week, 2 days ago or yesterday, last 2 days of this week, is we've started to correlate this directly to admissions, numbers of admissions. We don't care about individual devices, but numbers of admissions and COVID positives in our hospital. And I'm excited to show you early next week what this looks like for every hospital in Hillsborough County and potentially every hospital across the 51 hospitals we have. The exciting thing here is that this starts to move into a predictive space. If we anticipate the mobile risk score will go up from what you see there at the end, about a 0.27, 0.3. As it doubles, you can imagine that the probability 14 days later, and we're not exactly sure, we have to run it, 12, 14, 18 days later, that demand will be placed on Tampa General Hospital because of the movement behavior of the 5 geo-fenced areas around Tampa General will probably increase. And we can begin to be predictive. And the final slide I want to show you on the movement dashboard, next slide, is the fact that working with the steering committee and your leadership team on the emergency front, we have an opportunity to establish some parameters for study. This chart represents a particular Saturday where we looked at 8 hours and we made a simple parameter. Give us a geo-fenced area, basically a square block, where more than 150 mobile devices move through that square block in less than 8 hours. And you see that there was a particular beach, not all the beaches, a particular boathouse club area, not all, a church, not all churches, etc. What does this tell us? Well, it tells us in a prescriptive way that we have an opportunity to very intelligently and quite disciplined way, working with leadership of the county, the city, and the region to try to understand more effectively where we could identify clusters that are occurring and perhaps proactively, prescriptively send teams to evaluate and then work with the locations involved. It turns out that when you think about the nature of risky clusters, there really are two natures. One is this geofence behavioral based, and the other is the acuity demographic risk based, which is what we were talking about with the elder care facilities. Next slide. And I'm going to wrap up. So where are we today and where are our actions moving forward? The largest risk to COVID hospital, or the largest risk to the opening is to hospital capacity. And so what we have an opportunity to do is use this entire dashboard, the input and the outcomes dashboard, the capacity dashboard, the testing dashboard, and this mobility dashboard to triangulate and map and target the high risk areas of capacity consumption in our region. And those include the nursing homes and home facilities. They include conducting targeted daily cluster analysis and the evaluation of daily correlation in the graph by hospital. We want to be data-driven, and the data-driven approach is to really think about centralizing these comprehensive dashboards, spread capability and outcomes, and make them available to you as the EPG on a daily, weekly basis. Then explore with the steering committee and test key parameters in the model, pose tough questions, and find insights in the data so that it's truly data-driven. Those clusters that I showed you, we didn't anticipate, we didn't predict, we let the data drive that. And it gives us then the ability to be actionable. Let's create the daily feeds to the coordinating officials. Let's deploy mobile testing teams. Let's deploy the mobile care triaging and monitoring teams in conjunction where this mobility data would anticipate that if we don't treat a cluster or a location effectively in advance, they will show up at our test facilities and they will show up in our hospitals. And ultimately, we are working over the next 2 months in this effort to automate how and when to send the alerts and learn how to use, and this is critical, how to use the other data sets that you're familiar with, the syndromic, tracing, and demographic data sets to improve the model accuracy. Ultimately, we want to move from continuing to increase the power and accuracy of the predictive models, which you really haven't had before, add the prescriptive modeling and generate key insights, and generate these actionable alerts for immediate response. Next slide. With that, I do want to recognize the steering team. You'll notice some of the members on the steering team, all of whom have been co-opted, brought on board in the last short period of time. What are your questions?
Well, Dr. Mullarkey and Dr. Chang, let me thank you very, very much for your in-depth presentation. I think that's, it's eye-opening. It really is eye-opening, and what we need to be prepared for and on the lookout for. And I hope that maybe Monday you can come back, or one day next week, Monday or Thursday, with that heat map. I think that is very interesting to see what's happening here and where we are with the changing of the colors. So I do appreciate that, and hopefully we can get you back, if not Monday or Thursday of next week. Ms. Snively, you recognize.
Thank you, Chair. I just had a quick question on the movement dashboard, which was, I think, slide number 13 on the PowerPoint presentation, and it was the one with the geo-fenced 150 devices in a certain square foot area in 8 hours. Could you tell us what was that in what date that was? I don't see a date on the PowerPoint slide. Or was that, what period of time was that?
That was a 1 8-hour period on a Saturday about 3 weeks ago. So that was during the shelter at home period. And please forgive me, I just don't recall the particular Saturday.
No worries. I just was curious what day that was. And I'd like to continue seeing the risky cluster ID, the movement dashboard, if you are bringing more information back, like updated heat maps. I think that was interesting information to share as well. Thank you.
Thank you very much. And to your point and to the chairman's point, our goal, Mr. Chairman and EPG, is to provide you with a dynamic dashboard on a daily basis. And certainly starting next week, we'd like to do that on Monday and Thursday. Of course, now that you've been oriented to it, we could make it briefer, but absolutely make that an integral part of the communication so that you have a comprehensive, holistic way of looking at these inputs and the outcomes, if you will.
Thank you, sir. Mayor Ross, you recognize.
Thank you, Mr. Chair. Thank you, doctors, for this presentation. It's fascinating stuff, but also a little scary to me anyway. I'd like to ask you about some of that. I'm no stranger to using cell phone data. We use it all the time, but it's in the aggregate. I mean, we do transportation studies, we time red lights by cell phone data. We do a lot of stuff with cell phone data, marketing, all kinds of things. But this, to me, seems a little more granular than what we're used to doing. What we're used to looking at is hundreds of thousands of cell phones, and now we're looking at, and I know that at the beginning you talked about, no personal information and so forth, but there's several things in the presentation that seem to at least contradict that, or maybe confuse me into thinking it's contradictory. there's one place where we talked about identifying the top, I don't know, 5% of at-risk movement or what, but if you can identify the top 5%, you're looking at granular cell phone data. And the other thing is it talked about the cell phones that are demonstrating at-risk behavior. It's not cell phones we're tracking, it's people. And those cell phones or people that show up at TGH within 14 days. Well, if we're able to do that, we know which phones we're tracking, whether we publish that or not. And then on the last page, perhaps most alarming to me anyway, on the last page, the movement dashboard risky cluster ID page is the one I'm looking at with the little dots. One of these little dots is a private standalone home. And so somewhere along the line, we've taken this cell phone data and isolated it down to somebody's house. And presumably, at some point, we could use this data, you said so yourself, to be proactive, and somebody's going to eventually go knock on their door and say, hey, we track these cell phone activity to your house. And I'm not trying to be difficult. I recognize this is all done with the best of intentions and trying to save lives, but I also find it a little disturbing, a little scary that we are heading to the point where we're going to show up at people's houses because of we're doing cell phone data. This just seems a little big brotherish to me. And like I said, I don't mean difficult. I understand that it's being done with the best of intentions, but I also find it a little disturbing. Thank you.
Sure. And we can address it in a two-part approach. The first part of the address of the discussion, I think, really starts with your last point, and that is the dashboard itself doesn't direct behaviors of our emergency response teams. And what this has to be married with is the policies of those teams. And Chief Jones and his team and the teams at each level of our governmental organizations obviously have a responsibility to use this data in conjunction with their standard policies and approaches for acting upon that, right? And we don't presume as medical professionals or data scientists to suggest how that's going to happen. We're counting on you as county officials and your policies and procedures for the way to address that. The second question, the second point, which is really your first point, is yes and no. Obviously, what we are doing is we are scoring the individual devices, but we're presenting in the aggregate. So when we look at the presentation, and the mobile devices are a wide range of devices and device types. And I think it's imperative that we understand that they are de-identified from any personally identifiable information. So when we talk about mobile devices that are counted, and literally it's counts at a medical facility or a testing facility, we're not necessarily finding a correlation between those and any other mobility information. We don't have to, because what we're looking at is in the aggregate predictive power of many, many devices and many outcomes. And individual devices and outcomes do not provide any predictive power for us. And they don't help us understand the key criteria around, are we going to run out of bed capacity? Which is really what this mobile dashboard is all about. Are we going to run out of bed capacity as we open and phase in our opening? And if we are there opportunities, again, for the policy team and the procedural teams at the county and the city level to intervene appropriately to help people help themselves and not spread the virus in a way that's going to overwhelm our medical capabilities? Does that answer your question?
Yes, thank you, Doctor.
Thank you so much. It's a great question. We're highly sensitive to the privacy issues and intend to do this completely compliant with all laws and regulations of our state and our country.
Commissioner Merman, you're recognized.
Thank you, Mr. Chair. And this question would be about how we use the data to start to make our decisions. And I guess I need to ask Dr. Holt. Is he still on the line, Dr. Holt?
Dr. Holt, you still there?
Yes, ma'am. Yes.
So did you review the report?
I did receive it today. I haven't had a chance to, just sort of absorbing it as we present it.
I know.
Yes, ma'am.
It's a lot. And really, I want to commend the team. It's the predictive analytics is really the way to go. And this is definitely a good start for us. My question is given all these facts, you've got the facts, you've got your percentage of hospitalizations and deaths by age group. So everybody age 65 and up is very vulnerable. Would it be better for us instead of, we're doing widespread testing. Yes, it's very, very important. But would it almost be better for us to concentrate the testing, like taking the mobile testing down to Sun City Center, going to all the nursing homes and ALFs, any senior center, any congregate center that has people 65 and up? Wouldn't it be better for you and working with our county and city officials and working on a testing plan that more focuses on that age group, so that once we get a handle on that, yes, our cases still may be high, but they're not going into hospitalizations and they're not resulting in death?
Yeah, Matt, I'll take some of that one. That's a very good insight. And I think one of the things we have to consider is when we test, it's only one period of time that we're testing. And so we want to build off of what you just said and use the movement data to identify high-risk areas that we need to go back maybe 2 or 3 weeks later and retest, and maybe identify the 1 or 2 or 3 asymptomatic positives versus waiting until it gets to the 40, 50, 60 outbreak. And it's where do you test? And I think the second question to your point is how frequently do you go out there and test? And we want to be able to use some of this movement dashboard to create those high risk areas that we can then deploy those resources.
Okay, thank you.
Dr. Mullarkey, Dr. Chang, you see no more questions. Thank you very much. We look forward to seeing you in the future.
Thank you so much. Thanks for the sponsorship of the county and everything we've done. Thanks.
You're welcome. Thank you. Child Care Report, Ms. Angela Chowning.
Hi, good afternoon. Let me get my presentation up for you all. First, before I begin, I'd like to say thank you all for allowing me to present today on the child care community here in Hillsborough County. As we know, child care providers were deemed essential during this pandemic crisis, and it was essential for them to be open so that the other essential workers would be able to serve our community in the way that they needed to. In Hillsborough County, there are approximately 1,060 licensed child care programs. In response to the COVID-19 pandemic, many of the providers opted to close for a variety of reasons. First, just for concern out of health for their families and staff, lack of the enrollment, parents who are keeping their children home, and or due to some of the strict operational restrictions that were initially enforced under the state executive order if they wanted to remain open. And some of those restrictions included keeping groups of 10 in classrooms, no intermingling of these groups during the day, and strict sanitizing procedures. At the height of the pandemic, we had about 46% of the child care programs closed. Slowly but surely over the previous few weeks, we have seen some of them slowly reopening, and we now have about 35% that have remained closed. So to give another perspective, I received some data from the Urban Learning Coalition of Hillsborough County, and I think Mr. Gillette is on the call with us. And they're the funding source for subsidized childcare. That closures from these childcare facilities have left about 3,000 available slots available for families that would qualify for that. In the early childhood community, however, as a response to some of the struggles that the childcare providers and families are going through, there have been a lot of agencies working on their behalf and providing much needed guidance and resources to our families and childcare providers. The first bullet would be the Early Learning Coalition of Hillsborough County. They did receive federal funding as part of the CARES Act. And with those dollars, they have initiated a program to provide 3 months of child care subsidies for families of healthcare workers and first responders enrolled in the programs of subsidized providers. In addition, those child care providers are receiving a $500 per child per month to serve those families. So, the Board of Hillsborough County is providing parallel supports to healthcare workers and first responders that are enrolled in the private pay program. We also have a quality early education system, which is a collaborative program between Hillsborough Community College and Hillsborough County Child Care Licensing, funded by the Children's Board. And that entity has been offering virtual workshops for child care providers and ongoing early childhood opportunities for families to help keep their children engaged while they are at home. For the families of those providers enrolled in the quality early education system, the Children's Board has been offering financial assistance for those that are in need, and a big help. Child care licensing, in cooperation with the Early Learning Coalition, in addition, will be seeking approval shortly from the Board of County Commissioners to waive the renewal license for child care providers for the month of May and June. Due to the closures, many of our child care providers obviously are having a cash flow issue. And so we're just looking for any way that we can to just kind of help out as much as we can. These agencies' main focus, of course, is to assist in stabilizing and supporting programs that are open and to help facilitate a return to full operation. We haven't received any indication that any of the providers are going to close permanently because of this. I think that's sorted out perhaps in the next few months. However, there are some factors that are causing concern out in the child care community. And due to their capacity being sharply limited, those operational restrictions that were initially put in place are still recommendations that the providers are trying to adhere to because they are recommendations by the CDC. So because of that, their capacity obviously is limited. So their concern is that once parents, once the state starts opening up more and more, then they're not going to be able to accept all of the families. I feel like it's putting them in a position, and it is. They're having to make some calls. Also is their inability to get adequate numbers of supplies for operation. We've heard of, you name it, a failure to be able to get milk in the quantities that they needed anyway, to cleaning supplies, hand sanitizers, those types of things. Another concern would be a shortage of child care provider staffing that are available for work. A lot of folks have been laid off, or they're hesitant to come back to work because they're afraid for their health. A lack of clarity is out there regarding the payroll protection. They're not exactly sure how to maneuver through that system and kind of explore what those parameters are so they're sure of what they're doing. And then lastly, with the closure of public schools, we're not sure whether the host programs, which are their school district after school programs, are going to be reopening. They take a very large number of school-age children in the summer. We're not sure if that's going to be out there as well as other summer camps. So community-wide, I think we're wondering where those children are going to go. All in all, the providers are very resilient. They're very dedicated. They're very in tune to the orders that are out there, and they're trying to comply. And they certainly have played a very important role during this. I thank you for your request, and I am happy to answer any questions.
Thank you, Ms. Chowning. I don't see any questions at this time. Thank you very much for your presentation. We appreciate it.
Commissioner Miller, I do have a question, please.
Okay, Commissioner Overman, you recognize.
Thank you very, very much. And Ms. Channing, thank you very much for your report. Our children are critically important to our families, and with multi-generational families in our community, how we address the need for childcare is so critically important. With Governor DeSantis's phased approach on reopening our state, having adequate childcare is very important. As you indicated, we based on the increased number of openings since the height of the pandemic, we've got 688 licensed childcare programs open at this point, an increase of 113 since the height. And so I know that some of that demand increase is where childcare centers have been able to try and figure out how to accommodate the guidelines or the rules associated with, the 10 students per room and those kinds of things. So I think it's important that we address, who sets the rules for how people that provide childcare, whether it's summer programs or licensed childcare facilities or schools or, our programs that are administered through our children's board, who sets those rules and how are those individuals being communicated? The governor's orders limit to each classroom to 10 people. I mean, is it very clear what those guidelines are and that they are until we know that we're able to keep children safe, how they accommodate that? And can we help those child care centers by educational programs or things like that so that they can get ready?
Thank you for that. I would say that it is not very clear. And I think a lot of the reason for that is that there's a lot of information coming from a lot of different directions to child care providers. I am on weekly calls with the Department of Children and Families Child Care Licensing, and really they're the ones setting the guidelines for these things, and we are following. The CDC recommendations are still in place. They're very quick to say that they are strong recommendations. There's no enforcement from the licensing perspective anyway, in terms of them doing it, but they are expected to follow those. In terms of our office, we are educating them on a weekly basis, or as soon as we get information on any updates that come about. And I think the state has done a decent job of doing that as well. So I think the word is out. I think what child care providers tend to look for, because they're so ordinance oriented, is to look for something that's absolutely in black and white, that they need to follow this, this, and this. And information seems to be coming from just a variety of places. So that makes it a little bit tough. But we are doing the best we can to get the recommendations out there. They are out there. But to navigate through that and help them understand what that means for them, and then how they can run their business going forward.
Thank you very much. No, it needs to be clear as much as possible because the risk is great to multi-generational families. So thank you very much for your report. I appreciate it. And thanks for all you're doing to help our kids get places to go. So.
You're welcome. Thank you.
Commissioner Merman, you recognize.
Thank you, Mr. Chair. I think Gordon Gillette is on the phone. Actually, the whole child care arena, as you probably know, being in the legislature, is very much regulated by the state. And, they're now famous for getting all the word out. But I just wanted to see if Gordon's still on the phone, if he wanted to comment on anything.
Mr. Gillette, are you on? Mr. Gillette?
No, he must not.
I see him on here, but I don't know if he's. I think he's muted.
Oh, maybe he needs to unmute.
Mr. Gillette, did you unmute yourself? I see him trying. Mr. Gillette?
No.
Mr. Berg, can you make sure that he's unmuted at the president level?
I'm
Yes, ma'am.
looking at it now, Commissioner Overman. He's trying. Mr. Gillette?
I actually don't think he's in an office. I think he's in his car.
He looks like he just unmuted himself, but it's probably not able to do that. No, Commissioner Merman, he's not able to do.
Yeah. Well, we can have him chime in on Monday if he feels there's something else to offer.
All right, thank you. Okay, Ms. Chowning, thank you very much. County Attorney presentation, Ms. Beck.
Good afternoon, Chairman Miller and EPG board members. Christine Beck, County Attorney. You have been provided a draft order extending the local state of emergency. It was previously distributed as part of your packet materials. That is for your consideration. The order would extend the local state of emergency for an additional 7 days.
Thank you. Is there a motion to extend the local emergency order?
Move to extend the emergency order for another 7 days.
Motion by Mayor Ross. Is there a second?
I'll second.
Second by Commissioner Merman. Is there any discussion? I see no discussion. Please call the roll. Clerk? Is the clerk there? Okay.
Chairman Miller, this is James Brewer. I'm going to manually unmute Joe, the clerk. Joe, are you there?
I am here.
Go ahead, Joe.
Miller?
Yes.
Overman?
Yes.
Merman?
Yes.
Cronister?
Yes.
Castor?
Yes.
Ross?
Yes.
Lott?
Yes.
Snively?
Yes.
Motion carried 8-0.
Thank you. The floor is now open for any EPG member discussions. Is there any discussion today? Anyone have anything to bring forth? Ms. Snively, you recognize.
Thank you, Chair. And before I make some comments, I just wanted to thank Ms. Chowning and thank you, Commissioner Overman, for requesting that information about child care services. I think that's integral moving forward to reopening our community. But I just wanted to kind of take advantage of this public platform just to give you some information about what's happening in the school system briefly. So that you know what impact it's having in our school district. So to date, we have distributed over 4 million meals to our students in Hillsborough County. We have checked out over 38,000 electronic devices to our students for their distance learning. Our attendance is at about 98%. In our school district, which gets measured by students who are checking in at least weekly with their educators or their administrators. We still are planning, unless CDC guidelines or the Department of Education or the governor changes their status, we still are planning on moving forward with the 2021 school year in August. But we will have some summer programming for students who need additional programs and instruction over the summertime to prepare them for the next academic school year. And graduations have been postponed until July. So all seniors will still have the opportunity to participate in a traditional graduation ceremony. So today, that is the decision. Today, we'll confirm that by July 1st. But we have the 13th through the 20, I believe it's the 23rd, we will have our traditional graduation ceremonies at the Florida State Fairgrounds. So I just wanted to give a quick update on what's happening in the school district. Thank you for allowing me to do that.
Thank you, Ms. Darby. We appreciate it. Thank you very much. Any other discussions by any EPG member? I don't see any hands. Mr. Merrill, anything else?
No, nothing else today, Mr. Chair.
Okay, very good. In that case, thank you all for being on the call or the web meeting. Have a great weekend. Stay safe, and we're adjourned.
Thank you.
Thank you. Happy Mother's Day.
Happy Mother's Day, all the mothers.
Happy Mother's Day.